Ma'am, shall we start, ma'am?
Yeah, sure.
Yes. Good evening, everyone. Thank you for joining with us today in this wonderful session. Once again, from Dr. Kohila, ma'am, uh, assistant professor from Department of Anatomy in Madurai Medical College. She is a well-known anatomist and a well-known teacher, a guide, and one who cares for the students and taking such a wonderful classes before exams for the benefit of students. Today, it's our pleasure to welcome you, ma'am. Thank you so much for once again joining with us. Today, we are going to have a wonderful session from this date. We are going to have a wonderful session every month, the continuation of the Grace Anatomy session, which we had earlier last year. This year, this is a Grace Anatomy 2.0, and wonderfully once again taken by Dr. Kohila, ma'am. Today, we are starting with most difficult topic we all think in anatomy, that is the head and neck. So I think today, ma'am will make it easier for you all, and you can excel whatever exam it is, maybe UPG or a next exam or your initial. So thank you so much, ma'am, for joining with us today, and let's get into the session quickly. Over to you, ma'am.
A very good evening to one and all. Thanks, Raghu. Thanks, Medusane team, for giving me this opportunity. Yes, I'm Dr. Kohila. Welcome all to this session, rapid revision of head and neck, right? So, yes, guys, I don't want to waste your time. Of anatomy, of different topics in anatomy, head and neck anatomy is extremely very interesting and very important, because every part of it, every topic that you come across in head and neck anatomy will be linked to some clinical anatomy, right? Isn't it? ENT, ophthalmic surgery, every part of head and neck anatomy is very, very, very important. Okay. And it is very vast, right? Head and neck, it's going to be covered in your nearly 2 to 3 months during your first MBBS would have been covered. Okay. Yeah. So now, when I say rapid revision, we are not going into the depth of each topic. Yes. So close towards your exams, I just want to concentrate on the high yield topics, right? We are going to concentrate on the high yield topics. And under these high yield topic, I'm just going to give you the extract, the key points alone, right? The key points alone, yeah, for each topic. For example, even today morning, I was telling in my dissection table. Yeah, for example, I'm just giving you one thing, palatine tonsil, isn't it? Yeah. So during your first MBBS, you would have learned it as an essay question, and then in ENT or surgery, right? So what are the key points you would like to take home for this topic? Yes. So the structures which are present in the lateral wall of the tonsil that forms the tonsillar bed. Yes, you should know what are the muscles there, what vessel, what nerve is related. And then coming to the blood supply of tonsil, what is the vessel responsible for reactionary hemorrhage? Yes, you know the answer. It's the palatine the paratonsillar vein, right? Paratonsillar vein. What is the chief artery which is going to supply the palatine tonsil, right? The branch from the facial artery. And whenever you get a tonsillitis, an infection of the tonsil, there's a referred pain to the ear, right? So what is the nerve responsible carrying pain sensation from the tonsil? And why there's referred pain in the ear? Because it's going to be innervated by the glossopharyngeal nerve. Coming to the lymphatic drainage, the chief group of lymph nodes that drain your tonsil is the jugulo-digastric. And development of tonsil is from the second pharyngeal pouch, right? So if you ask me the key points for palatine tonsil, I would list only these 6. Yes. So whatever be the exam that you're going to face, whether it's your university exam or whether it is your NEET PG, INICT or next, whatever be the pattern of exam question, right? The topic of importance, the topic of interest is going to be the same, for which you should know the key points. Okay. So another thing which students, they keep asking, how to remember things. You know, anatomy is very, very, very volatile. I understand, right? Over a period of years, we reinforce and we remember it, right? Still, it's very volatile. So if you try to remember these key points, right? And images, the image-based questions that appear, yeah? Anything, if visual memory, right? Retain it in your visual memory, and then There are a lot of mnemonics. Even in today's session, I'll be covering a lot of mnemonics, okay, which I myself have tried to frame it. So remembering the mnemonics. And the fourth point I would suggest is a table. For example, in head and neck, you have the parasympathetic ganglia. So comparing the 4 parasympathetic ganglia, if you make a table, that will save a lot of time before your exams. You can make a quick revision of that. So try to make a comparative table, and every point try to correlate with clinical anatomy. Understand the concept, okay? So whatever, as I told you for palatine tonsil, these are the 6 important points which you should definitely know. So whether it's a direct MCQ, whether it is a clinical scenario, whether it's an image-based question or whatever exam it is, these are the key points on which the question is going to be framed. Got it? Okay. So this is what we're going to do in the next 1 to 1.5 hours. The important topics in head and neck and the key points. Okay. Yes. Are you with me? Can you try to answer this question? Can I have the answers in the chat box? Yeah, you can see the question, right? So which of the following is not a feature of the palsy shown in the image? What are your answers? Guys, am I audible? Am I visible? Yeah. Yes, can I have the answers in the chat box? So what is the image showing? It's the Bell's palsy or the lower motor neuron type of facial palsy, isn't it? Yeah. Guys, am I audible? Yeah, you can enter in the chat box your answers, right? So the picture, the image is showing you Bell's palsy or lower motor neuron type of facial palsy. So what is the side that is injured? This is the right half. This is the left half of the face. So which side facial nerve is injured? It's the left facial nerve palsy, right? So what are the features that you see here? Yeah. So given from the options, there's loss of transverse wrinkles on the forehead. So what is the muscle paralyzed? It's the frontal belly of occipitofrontalis. Obliteration. This is your nasolabial fold. Yes, you can see it on the left side, obliteration of the nasolabial fold, right? Why so? Because of the paralysis of muscles of upper lip. Inability to open the eyes. Is that a feature of Bell's palsy? No, right? So what is the muscle which opens your eyelid? Levator palpebrae superioris, that's going to be supplied by the oculomotor nerve. Okay, so what will happen in facial palsy? The patient will have, yes, inability to close the eyes. Inability to close the eyes because of paralysis of which muscle? Orbicularis oculi. So option C is wrong. Food accumulates in the vestibule. What is the facial muscle that's paralyzed? It's due to paralysis of buccinator. Okay. So what is the reason for Bell's palsy? We can see the facial nerve coming out of this foramen, right? What foramen is it? Stylomastoid foramen. So injury to the facial nerve, yes, after it exits from the stylomastoid foramen, that is going to be called as a Bell's palsy, a lower motor neuron type of facial palsy, right? Soon after it exits the stylomastoid foramen, where does it enter? It enters the parotid gland. But even before it enters the parotid gland, you can see a branch coming out of the facial nerve. What is it called? The posterior auricular branch. What muscle is it going to supply? The occipital belly of occipitofrontalis. What is the second branch that you see here? The temporal branch of the facial nerve. What are the muscles innervated by the temporal branch? Frontal belly and upper part of orbicularis oculi. This one running along the zygoma, the third branch, that is the zygomatic branch. It supplies the lower part of orbicularis oculi. You can see the parotid duct here, just above and below the parotid duct. Those are the upper and lower buccal nerves. Upper buccal nerve supplies the muscles of upper lip. Lower buccal nerve, what muscle does it supply? Yes, that's an important question, right? The lower buccal nerve, it goes on to supply what muscle? Yes, you can enter in the chat box. Buccinator, right? Buccinator. Very good. And this one, lower down, running along the lower border of the mandible, which is surgically important. What nerve is that? Marginal mandibular nerve. Why am I telling it is surgically important? Whenever you're going to make any incision over the submandibular region, okay, it should be 2 to 4 centimeter below the lower border of the mandible so that you don't damage this nerve, okay? So the relation of marginal mandibular nerve to submandibular gland is very important. Lastly, coming to this nerve going towards the neck, what is it that called? It's the cervical branch that supplies the platysma. This nerve also should be taken care of while you're making an incision over the submandibular gland. Okay, these two nerves, right? Now, this pattern of branching of facial nerve within the parotid gland is called as pes and serenus. Why does Bell's palsy occur? Idiopathic. And then any trauma to the facial nerve at its exit from stylomascoid foramen or even exposure to cold can trigger facial nerve palsy, right? A few words about this muscle. What is this muscle pointed out here? It's the buccinator, right? A few important points related to buccinator. So this buccinator, the upper fibers come from maxilla, lower fibers come from mandible, opposite the molar tooth. Now, can you see a white structure here? What is it called? Yes, that is the pterygomandibular raphe. So our buccinator middle fibers originates from the anterior aspect of pterygomandibular raphe. Now, who's going to tell me? These fibers which originate from the posterior aspect of pterygomandibular raphe. What is that muscle? Yes, that is the superior constrictor muscle of pharynx. Now, what is this fascia which is going to cover the superior constrictor and then extend to cover the buccinator? Normally, the muscles of the face, they don't have a facial covering, right? But this buccinator is going to be covered by a fascia, buccopharyngeal fascia, just because it's originating from the pterygomandibular raphe, which also gives origin to superior constrictor. Okay, this is very, very special. Now you see something piercing the buccinator. Can you tell me what is it? The parotid duct. Do you know any other structure piercing the buccinator? Yes? Any other structure that pierces the buccinator? Come on. Yes? Buccal branch of mandibular nerve. This buccal branch of mandibular nerve, it pierces the buccinator from inner aspect to supply the overlying skin. It is a sensory nerve. What is the action of this buccinator? It is located over the cheek, right? So it compresses the vestibule. It is also called the, yes, the trumpeters or the whistling muscle, right? So what will happen in this paralysis of buccinator? Yeah, the food accumulates. The buccinator cannot compress the vestibule. The food accumulates in the vestibule of the mouth. So facial nerve, Bell's palsy, you can write 6 features, right? So what is the first one? Loss of transverse wrinkles on the forehead. Done. Second one, inability to close the eyelids. Third, loss of nasolabial fold. Fourth one, what accumulates in the vestibule? The food accumulates in the vestibule due to paralysis of buccinator. And the fifth one that you see here, what is about the angle of the mouth? Drooping of the angle of mouth, right? On the side of the paralysis, and orbicularis oris will be paralyzed. So the patient will not be able to close his mouth. So there'll be, yes, sixth point, drooling of saliva. So these are the 6 features that you have to remember for facial nerve palsy. Now coming to the last point about facial nerve palsy, yes. So this is the upper motor neuron, lower motor neuron facial palsy. What do you mean by upper motor neuron? The neurons which are situated in the cerebral cortex. You have the right and left cerebral hemispheres, right? Lower motor neurons are the ones which are situated in the brain stem and the spinal cord. So you normally know the right cerebral cortex has control over the left side of the body, and the left cortex controls over the right side. So it's the contralateral side. Whereas the lower motor neurons, once it exits out of the brainstem or the spinal cord, it's going to control over the ipsilateral side. So this is your, right half, left half. So what is the nerve injured, whether it's the right facial nerve or the left facial nerve? It is the left facial nerve, right? Okay. So upper motor neuron, as you see in the image, left side palsy has affected the right, and lower motor neuron, left side palsy, left half of the face. But what do you appreciate in the upper motor neuron type of palsy? The upper face is bad. What is the reason? Because the upper face, right, it is under the control of both the cortex. It is controlled by both the cortex, by cortical representation. So even if the neurons coming from one cortex is going to be affected, the other cortex is going to control both the sides of the face. Okay, so remember, upper motor neuron, upper face is bad because it has bicortical representation. Done. So that's all about the facial nerve palsy, Bell's palsy. Any doubt in this? Now we'll move on to the a little lighter side of head and neck. Okay. Yes. Who's going to tell me? When Ram proposed, Sita responded by moving a atlanto-occipital joint. So what is the answer? Yes? What do you mean by that? What was the answer given by Sita? Joint of S or joint of no? Which one do you want to choose from? Yes? So I'll move ahead. Yeah. So we are talking about the joint between the atlas occiput and the atlas and axis. So this is your first cervical vertebra. It's also called the atlas, isn't it? And this is your second cervical vertebra, axis. Yeah. So the joint between the atlas and axis. Yeah. It's called the atlanto-axial joint. So it has two components, one in the midline. What is this process of the axis called? Dens, isn't it? So between the dens and the atlas, we have a median atlanto-axial joint. And here, between the facets on the atlas and axis, that's the lateral atlanto-axial joint. So this median atlanto-axial joint, yes, it is an example of pivot type of synovial joint. Lateral is plain. So what is the function of pivot type of synovial joint? It permits rotation, isn't it? Where else in the body do you get to see pivot type of synovial joint? Anyone who can tell me? Yes. Pivot synovial joint is found in the, yes, between the superior and inferior radioulnar joint, which permits supination, pronation of your forearm, isn't it? Okay, so the median atlanto-axial joint, which permits rotation movement of the your neck. It's called as the joints of no, right? And this joint between the, yes, what bone is here? This is your occiput. This is your atlas, right? So this is the atlanto-occipital joint, which is an example for anyone who can tell me what is its example of, what type of synovial joint it is. Ellipsoidal, right? It is an ellipsoidal type of synovial joint which permits what type of movement? Flexion and extension at the synovial joint, which means it can just bend and straighten your neck. So these are called as joints of, yes. Okay, so what could be Sita's response to Ram? Yes, atlanto-occipital joint. Yeah. So what's the answer? Come on. Yes. Atlanto-occipital joint, joints of yes. Atlanto-axial joint, joints of no. Another important thing related to this craniovertebral joint is that, yeah, you see the dents fixed to the atlas. There's a ligament bridging here. Yes, holding the dents in position. It's called the transverse ligament or the alar ligament of dents. Okay, so what happens in suicidal hanging? How does death occur? Yeah, so either rupture of this transverse ligament of dens or the alar ligament of dens or fracture of the dens itself. Can you appreciate it here? Yeah, what will happen? So the dens is kept in position by this ligament. The ligament is going to rupture. The dens is going to move out of its position. And what is that within the vertebral canal? The spinal cord, right? So compression of the dens over the spinal cord or the lower part of the medulla, which has the vital centers, right? That leads to death. Yes. Now, moving on to the next topic, okay? Yeah. What is A? What is B? Who's going to tell me? Yes, capal hematoma, caput succedaneum. Yeah, we'll see few points about that. So you know the 5 layers of scalp, isn't it? Skin, connective tissue, upper neurosis, loose areolar tissue, pericranium, which is called the dangerous layer of scalp, the loose areolar tissue. Now, with relation to capal hematoma and caput succedaneum, yes, we are concerned about pericranium. So you can see the pericranium here, right? If there is going to be a collection beneath the pericranium, what happens? You can see the pericranium. This is your suture. For example, remember, this is your sagittal suture between the 2 parietal bones. What happens to the pericranium here? It's going to dip between the sutures and continues with the endosteum. So any collection beneath the pericranium, what is there? Yes, you can tell me. Does it cross the suture? No, no crossing of the suture. And it will form a localized collection. Okay. But any collection that's going to be above the pericranium, okay, what will happen? Yes, it of course crosses the suture, right? And it will have a generalized swelling. Okay, so yeah, so you can see a localized swelling here, a generalized swelling, and a better picture of this. Yeah, so what is A? What is B? A is, yes, caput succedaneum. To remember it easily, remember C and S. Caput, it crosses the suture, right? And B, and it produces generalized swelling. What about B? Yeah, you can see the swelling on either side of the suture. It's not crossing the suture, right? So no crossing suture, and it's a localized collection. This is going to be capal hematoma. Any hematoma is going to take few months to subside, right? Okay, it's due to rupture of some blood vessel. Caput is just a soft tissue swelling that subsides within a week, right? So we are done with the third topic, okay? Now, what is the vertebral level of the pointed structure? So the midline of the neck has so many important structures which we should know, right? So what is the vertebral level of that structure pointed? Yeah, that is a cricoid cartilage, right? So what is its vertebral level? Yes, guys, you can enter in the chat box. Am I able to see your answers? Keep entering the chat box, okay? So are you with me? We'll start. Okay, so let's start from here. This is the symphysis menti. So what is symphysis menti? The mandible is actually formed by the union of two halves. And this two half will ossify, right? How will it ossify? Around what time will it ossify? Yes, around 1 to 2 years. Right. The next important structure you see in the midline is the diaphragma oris. What is diaphragma oris? What muscle contributes to the floor of the mouth? Mylohyoid, which is innervated by inferior alveolar nerve, right? Coming from mandibular division. And now coming to, yes, what is that bone that you see here? This is the hyoid. What is the vertebral level of hyoid? C3. The hyoid developed from which pharyngeal arches? Second and third. Can you tell me the artery which originates exactly at the tip of the greater corner of the hyoid bone? A branch of external carotid. Okay. Its origin from the external carotid is opposite the tip of the greater corner of the hyoid, the lingual artery. Okay. And then this one below the hyoid, connecting the hyoid and the thyroid, that's the thyrohyoid membrane. Now tell me the structure piercing it. The internal laryngeal nerve and superior thyroid artery. Right? What is the vertebral level of the thyroid cartilage? Yes, it corresponds to C4, C5, isn't it? And here we have the cricoid. The vertebral level of the cricoid is C6, isn't it? And then we have the isthmus. What does the isthmus correspond to? Posterior relation of the isthmus. They keep asking it frequently, right? Second, third, fourth tracheal rings. What is the upper border of the isthmus related to? The upper border of the isthmus, you can see sometimes an extension, right? What do you call it as? Yeah, the pyramidal lobe. Sometimes a fibromuscular structure, the levator glandulae thyroideae. What is special about the lower border of the isthmus? You can get to see a bunch of veins coming out of the lower border. What are they? The inferior thyroid veins. Another thing, sometimes apart from the superior thyroid artery and inferior thyroid artery, a branch coming from the aorta, yes, enters the thyroid at the lower border of the isthmus. Can you tell its name? Yes, that's the arteria thyroidea ima. Right. And just above the sternum, what is the space going to be called? It is the suprasternal space of Burns. What are the contents of the suprasternal space of Burns? Sternal head of sternocleidomastoid, a ligament connecting the clavicle of both the sides, interclavicular ligament, the jugular venous arch, the anterior jugular veins of both the sides connected by the jugular venous arch, and sometimes a lymph node. Okay, so the midline structures of neck are clinically very, 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 very important, right? Now, who's going to answer? Which of the following doesn't contribute to the floor of the carotid triangle? Yes. Yes, can I have the option? Come on. So where is the carotid triangle in this picture? Yeah, we'll do it. So this is the posterior belly of digastric, right? This is the superior belly of omohyoid. This is sternocleidomastoid. So this area you see here is the carotid triangle. There are 4 muscles that contribute to the floor of the carotid triangle. What are they? Thyrohyoid. From the hyoid, going up will be the hyoglossus. From the thyroid, going down backwards will be the inferior constrictor, plus one more muscle, middle constrictor. The sternothyroid will be a part of the muscular triangle, right? Is that okay? Any doubt? So remember the thyrohyoid. From the hyoid, hyoglossus and middle constrictor. From the thyroid, the thyropharyngeus part of inferior constrictor. These 4 muscles lie in the floor of the carotid triangle. What are the contents of carotid triangle? Quickly, we'll list out the content. So we have the carotid sheath, right? What does the carotid sheath enclose? Internal jugular vein. Yes. Common carotid artery, internal carotid artery. At its bifurcation, common carotid presents the carotid body, carotid sinus. External carotid artery with its 5 branches. So what are the 5 branches of external carotid given off in carotid triangle? Yes, superior thyroid artery, lingual artery, yes, facial artery, yeah, then 2 more, ascending pharyngeal artery and the occipital artery. Yes, 5 branches of external carotid. And then we have the vagus within the carotid sheath. Again, 5 branches from vagus. What are they? Pharyngeal branch. Yes. And then we have the superior laryngeal nerve, branch to carotid body, carotid sinus. Yeah, 4th one, the cardiac branches, cervical cardiac branches. And the 5th one, important. Who's going to tell me? The right recurrent laryngeal nerve. Why not the left recurrent laryngeal nerve? The left recurrent laryngeal nerve is given off in the thorax and not in the neck. Okay. And what lies in the anterior wall of the carotid sheath? We get to see the ansa cervicalis. In the posterior wall of the carotid sheath, cervical part of the sympathetic trunk. What are the other cranial nerves related to carotid triangle? Can you tell me 2 important cranial nerves related to the carotid triangle? Of course, the hypoglossal nerve and the spinal part of the accessory nerve. Also, you get to see the lower part of the parotid, and then in relation to the IJV, jugulodigastric and jugulo-omohyoid nodes. Right? So all these things in relation to carotid triangle. Now quickly about external carotid artery. So what is the extent of external carotid artery, right? From the upper border of the thyroid cartilage, which corresponds to C3 to C4, what level does it terminate? Neck of the mandible. Of course, you know the mnemonic, right? To remember the branches of the external carotid artery. The superior thyroid artery is the first branch of external carotid artery. Can you tell me the name of the muscle? Yes, guys, please answer in the chat box. Okay. What is the muscle which divides the lingual artery into 3 parts? Hyoglossus. Okay. And then the ascending pharyngeal artery is the only medial branch coming from the external carotid artery. The muscle dividing the maxillary artery into 3 parts is the lateral pterygoid. Okay? Yeah. As I told you, this is the greater cornu of the hyoid, right? The artery which arises opposite to it, that's the lingual artery. Below it, superior thyroid artery. Above it, facial artery. Okay, so now the facial artery, if you see, what are the landmarks related to facial artery is quite important. So we saw it arises opposite the superior corner of hyoid, right? And which triangle is it given of? In the carotid triangle. After that, it enters the digastric triangle. And what is the gland located there in the digastric triangle? You can see the submandibular salivary gland. It grooves the posterior aspect of the submandibular salivary gland, right? And then what does it do? You can see the mandible here, the lower border of the mandible. You can see it ascending over the lower border of the mandible, and the pulsation of the facial artery over the face. Where is it felt? What is the muscle that becomes like strong when you clench your teeth? Around the antero-inferior angle of masseter. Right? So these are the important landmarks for facial artery. What are the branches of facial artery you see over the face? Yeah, you know, this is the inferior labial, relation to lower lip, superior labial upper lip, lateral nasal, and this one is important, the termination of the facial artery, which is called the angular artery. Why is it important? This angular artery is going to anastomose with a branch from the ophthalmic artery called the dorsal nasal branch. So what? This ophthalmic artery is a branch of internal carotid artery. So the medial angle of the eye, where there's anastomosis between the facial artery and a branch from the ophthalmic artery, is an anastomotic site for ECA and ICA. External carotid artery and internal carotid artery. Okay. Now, what they ask is that, yeah, what are the branches of facial artery in the neck? Can you tell me? Yes. So the branches over the face is easy to remember, right? Yeah, there are 4 branches given off in the neck, in the digastric triangle. So what are they? Yeah, we keep forgetting it. So I tried a mnemonic for it. Okay. So branches to supply the submandibular gland. Branch to supply the palatine tonsil, the inferior tonsillar branch, which is chief source of blood supply to the palatine tonsil. And then we have the ascending palatine artery and submental branch. Okay, so you can try to remember the branches of facial artery using this mnemonic. Is that okay? Yeah. Coming to the next question. Can you try answering it? Yes. Injury to the pointed structure will result in paralysis of which muscles? Come on, waiting for your answer in the chat box. You can text in the chat box the answer. What is the pointed structure? So that is the posterior triangle, right? The yellow arrows pointing towards the spinal accessory nerve. What are the 2 muscles innervated by the spinal accessory nerve? Yes, trapezius and sternocleidomastoid, isn't it? So few things about the sternocleidomastoid, the key points related to sternocleidomastoid. Yeah, you know, that's a very important muscle in the neck, right? It's going to have 2 heads, the sternal head, the clavicular head. And there's one important triangle between these 2 heads. Yes, anyone know its name? The sedillot triangle. Sedillot triangle between the sternal head and the clavicular head. Why is it clinically important? This is the area they chose to, introduce a catheter into the internal jugular vein. Okay, that triangle is an important landmark to access the internal jugular vein. Okay, yeah. Now, the sternocleidomastoid muscle along with trapezius is going to be enclosed within the investing layer of deep cervical fascia. Its anterior border is related to the anterior triangle, posterior border to the posterior triangle. Now, this posterior border, there is a nerve point, okay, where the nerves emerge. Can you name them? This one going up is the lesser occipital nerve. This one going horizontally will be transverse cervical cutaneous nerve. And the one coming down, supraclavicular nerve. There's one going towards the ear. Yeah, that will be the greater auricular nerve. So that's the nerve point of the sternocleidomastoid. What is this condition called? Yeah, yes, Dr. Aruna, correct. Okay. So what is this? Torticollis or rhinic? Yes, spasm of the sternocleidomastoid. Now, I want you to figure out which one has undergone spasm, the sternocleidomastoid on the right or on the left. So for this, you should know the action, right? So if my right sternocleidomastoid is contracting, what will be the action of it? Yeah, if someone is going to slap on my right cheek, where will my chin go? Chin will turn to the left and the head will be on the same side of the shoulder, right? The chin goes to the left and the head will be on the same side of the shoulder, or on the side of the contraction. Okay, now can you tell me? Yes, so torticollis or rhinic is the spasm or contracted state of the sternocleidomastoid. Now, in this case, where is the chin turned? Chin is turned to the right, isn't it? So, this is a case of spasm of left sternocleidomastoid muscle. Do you agree with me? Have any doubt? Please enter in the chat box, right? Okay. So the spasm of the sternocleidomastoid is in a contracted state. What is this? Can you identify? So the sternocleidomastoid inserts into the mastoid process behind the ear, isn't it? So in case of otitis media, the pus can travel in different directions. Okay, so if it's going to break out through the mastoid process into the sternocleidomastoid insertion, what is this abscess called? Name of the abscess? Vissol's abscess, right? Yeah. Now, what is this in relation to the sternocleidomastoid? Branchial cyst, branchial fistula. This is the anterior border of the sternocleidomastoid. The cyst is always at the upper end, whereas the fistula is at the lower end. What is the embryological reason for this? You know, the pharyngeal arches are in the neck, right? Okay, that's the region of the pharyngeal arches. So the arches, what happens? How do you get your smooth neck? Yes, the second pharyngeal arch, the mesoderm of the second pharyngeal arch is going to overgroove the cleft of the other arches and fuse with the lowermost arch. So this gap that is created here, yes, that is called as the cervical sinus. The cervical sinus normally will obliterate. That's why you get a smooth neck. Sometimes the cervical sinus may persist as a cyst, which is called as the branchial cyst. That's found at the upper part of the anterior border. Okay. Now, if this second arch fails to fuse with the last arch here at the lower end, what will happen? There's a communication of the cervical sinus outside, right, with the exterior. That is called as the branchial fistula. So the fistula is found at the lower end. Okay, that's why it's found at the lower end of the anterior border of sternocleidomastoid, right? So we have seen so many things about the sternocleidomastoid, right? The clinical importance, including the cedular triangle, torticollis, Vissol's abscess, branchial cyst, and fistula. Now we'll move on to the next topic. You'll identify, help me identify. Yeah, I'll put this as A, B, C, and D. Can you enter in the chat box? Which of the following muscle is not innervated by hypoglossal nerve? Yeah, come on, waiting for your answer. Yes, come on, enter the answer. So this is an image showing you the muscles of the tongue, right? So what is A? A is coming from the palate. Palate above going towards the tongue. That is the palatoglossus. B is coming from the styloid process to the tongue, right? That will be styloglossus. And the Third one, seeds coming from the hyoid to the tongue, that will be hyoglossus. And the fourth one, fanning out, right, from the tip to the base of the tongue, that's going to be genioglossus. Very good, Heba, Ashwin, Aruna, that's the genioglossus, okay, D. Yes, so all the muscles of the tongue are innervated by hypoglossal nerve except the palatoglossus. Now tell me, what is the action of palatoglossus? Palatoglossus it's going to pull the tongue up, elevate the tongue. What is the action of styloglossus? It's going to, yes, from the styloid process, right? It will retract, pull the tongue backwards. Hyoglossus and genioglossus, what will happen? Will pull the sides of the tongue down, yes, and make the dorsum of the tongue convex. An important action of the genioglossus, right? Because it's going all the way from the tip to the base, it will pull the tongue out, the tip of the tongue out, protrude. It will protrude. Genioglossus is going to protrude. Okay, this is your genioglossus, fanning out. Okay, it's going to protrude your tongue out, and that is clinically important. So this is your right and left. Okay, when my left genioglossus is contracting, the tip is pushed to the right side. And when my right genioglossus is contracting, the tip is pushed to the left. When both right and left genioglossus contract, the tip is in the midline. Can you appreciate it? Okay. Now tell me, now this is the concept. You're going to apply this in the given image and give me the answer. Okay. So here, which side is paralyzed? Yeah. So the tip of the tongue is deviated to the right or left? To the left, isn't it? So the muscle injured or the paralyzed is your left genioglossus. So in hypoglossal nerve injury, the tip will deviate to the paralyzed side. So everything about the tongue is very, 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 very important, isn't it? Yeah. So usually ours is a nerve supply of the tongue. You can make out the sulcus terminalis, foramen cecum. In front of the foramen cecum, these are your circumvallate papillae, isn't it? What are these papillae that you see here? It's the fungiform papillae in the anterior two-third. Now, what are these ones? Yeah, these are in the posterior one-third, those are the lingual tonsil. This area here between the tongue and the epiglottis, right? This is your epiglottis. Between the glossoepiglottic folds, this is the vallicula. Okay. Now coming to the nerve supply of the tongue, we are dividing it into anterior two-third. This area, right? Posterior one-third. This one, and yes, posterior most, which is the region of the vallicula. Okay. And two types of sensation. What are they? Yes, general sensation and taste sensation. Okay. So anterior two-third, when I say general sensation, it means the sensation of pain. Hot and cold, you're able to feel, right? Pain, temperature, touch. All this from the anterior two-third is carried by the lingual nerve. Taste sensation is by the chorda tympani branch of facial nerve. Okay. Posterior one-third along with the circumvallate papilla, right? Along with the circumvallate papilla, yes, both general and taste sensation is by the ninth nerve. Okay. And the posterior most part, the region of the vallicula, general and taste sensation is by the vagus nerve. Right? So these are the things which have been frequently asked about tongue, muscles, nerve supply, and of course, do read about the lymphatic drainage also. The principal lymph nodes of the tongue are the jugulo-omohyoid nodes. right? Everything about the tongue is very important. Moving on to the next one, a lighter part. Which of the following is not a paired dural venous sinus? Yes, who can tell me? Which of the following is not a paired venous sinus dural? 1 second.
Just 5 minutes, ma'am will be joining you shortly. Kindly hold on for 5 minutes, ma'am will be joining shortly.
Guys, am I audible? Yeah, we'll continue. Raghu,
Yes,
am I
ma'am.
audible? Yeah, Raghu. One second. Yeah. So moving on to this, which of the following is not a paired dural venous sinus? Okay. Yes. So can you tell me what is the answer? You can enter in the chat box. A, B, C, D. Okay. So how many dural venous sinus are there? Anyone who can tell me? How many dural venous sinus are totally? 15. You can also remember another thing. Branches of maxillary artery. They also correspond to 15. Okay. But it's easier to remember them using a mnemonic. Right. So you'll identify with me the sinuses here. This is the superior sagittal sinus. This one, inferior sagittal sinus. The one lower here, that's the occipital, the smallest of all sinus. Right? Okay. Now, you can see a vein joining the inferior sagittal sinus. Any idea what is it? The great cerebral vein of Galen. This great cerebral vein of Galen, it joins the inferior sagittal sinus to form the straight sinus. Okay. Now, in this picture, you're going to tell me what is this? Transverse sinus. It's going to continue with the sigmoid sinus. This is the petrous part of the temporal bone along its superior border, superior petrosal sinus, along its inferior border, inferior petrosal sinus. Now, this is the area where you see a sort of a plexus, yeah, where the pons is going to sit there, right, over the clivus. That's the basilar venous plexus. Right. Now, coming to the most important one, on either side of the body of the sphenoid, cavernous sinus. Over the, along the lesser wing sphenoid, right? This one is the sphenoparietal. Sphenoparietal sinus. Now, yes, connecting the cavernous sinus in the front and behind. What are they? Anterior and posterior intercavernous sinus. Apart from this, we have the middle meningeal vein or the sinus and an occasional petrosquamous sinus. Okay. Now, how to remember all these 15? You can just try to memorize at least one. Okay. Yeah. This is the unpaired dural venous sinuses are 7 in number. So if you remember this, you can easily click off with the paired dural venous sinus also. Yes, that's the mnemonic you have to remember. The superior sagittal sinus. B is for basilar venous fluxus. I, inferior sagittal sinus. Yes, S is again for straight sinus. O is occipital sinus. A and P, what are they? Anterior and posterior intercavernous sinus. Got it? Okay. So this again frequently asked in your NEET PG or INICT. Yeah. The name the paired and unpaired dural venous sinuses. Okay. Yeah. Again, coming to the area of nasal cavity. Which of the following structure does not open into the probe space? So I'll probe this space. That's the middle meatus, right? Middle meatus. Can you enter in the chat box? Okay, which of the option doesn't open into the probe space? Come on. Yes. Waiting for your answers. Come on. Yeah. So it will be the posterior ethmoidal. Apart from that, what are the key points that you should know in relation to your nasal cavity? So this is the nasal septum. This is the lateral wall of nose. Okay. So what are the bones that you see here in the nasal septum? Can you tell me what is this bone? That's the perpendicular plate of ethmoid. This one green color below, yes, that's the omer. Okay, so these are the two main bones that contribute to the nasal septum. In the lateral wall of nose, what are the bones we get to see? Superior nasal concha, middle nasal concha, inferior nasal concha. Why is the superior and middle concha given a same color and inferior nasal concha given a different color? The superior and middle nasal concha are part of ethmoid, right? The inferior nasal concha is an independent bone. It is the longest of all the three, okay? Large and long. Next, the other important point about the nasal septum is that, yes, it's going to be divided into 4 quadrants, right? Antro-superior, antro-inferior, post-pro-superior, post-pro-inferior. So, in the nasal septum, over its antro-inferior quadrant, there's an important area called the Little's area. Even a small scratch there, a trauma there can cause severe bleeding. Why? Because there's a plexus of vessels situated there, which is called as the Kieselbach's plexus. What are the arteries contributing to these plexus? Yes, we have the anterior and posterior ethmoidal artery, which are again branches of the ophthalmic artery. Ophthalmic again is a branch of internal carotid artery. Okay, and other branches are sphenopalatine artery, greater palatine artery, which are coming from the maxillary artery. And in front, we have the septal branch coming from the facial artery. And we know that maxillary artery and facial artery are branches from the external carotid artery. So this is again another MCQ question. of the branches, which one is coming from internal or which one is coming from external. Okay, it can be put in either way. So nasal septum, antero-inferior portion, little's area, Kieselbach's plexus, branches from ICA, ECA, right? So this artery, okay, which causes epistaxis or nasal bleed. The artery of epistaxis, it's called, okay, sphenopalatine artery, branch from the third part of maxillary artery, right? Now, this is a picture again, nasal septum, lateral wall showing the nerve supply. So the roof is going to be from the olfactory nerve, the anterior part of it, anterior ethmoidal nerve from ophthalmic division of trigeminal nerve. Okay, no, fine. Now you can see the pterygopalatine ganglion here. That's the pterygopalatine ganglion. Branches from the pterygopalatine ganglion, maxillary nerve, they innervate the nasal septum and cavity. Okay. Now what I want you to appreciate is, can you tell me what is this area? That's the incisive canal. Now, there are two structures which are going to transmit it. Yes? Yeah. What are they? The one, you can see here running along the groove of the omer. Yeah, what is it called? The nasopalatine or the sphenopalatine nerve and vessels. Remember from its name, nasopalatine. It has to supply the nasal cavity and the palate. But it supplies the nasal cavity first, right? It supplies the nasal cavity and then exits out of the nasal cavity through the incisive canal. So the structure which exits out of the incisive canal is nasopalatine or sphenopalatine nerve and vessels. Now coming from here below, can you see here this one? Yeah. From the pterygopalatine ganglion, you see a nerve running along its lower border of the hard palate and then entering the nasal cavity. What is it called? That's the, yes, come on, tell me its name. Greater palatine nerve. Greater palatine nerve enters the incisive canal. Okay. So you should know what is the structure. After supplying the palate, it enters the nasal cavity to supply it. So structure exiting the incisive canal is your sphenopalatine. Entering is the greater palatine. Yes. Now coming to the meatus. Okay. Coming to the meatus that you see here. Inferior meatus, middle meatus, superior meatus. This is the sphenoethmoidal recess, which receives the opening of the sphenoidal sinus. Fine. Now, you know, inferior meatus receives the opening of nasolacrimal duct. What are the features you get to see in the middle meatus? You see a bulbous projection here, right? That is called the bulla. Below the bulla, you get to see a canal, a gutter-like thing, right? That is called the hiatus semilunaris. This hiatus semilunaris is going to continue upright as a blind pouch. That will be called as the ethmoidal infundibulum. Ethmoidal infundibulum. Okay. Now, on the surface of the bulla, can you see some pit-like depressions here? Yes. What is it due to? So, the bulla itself is produced by the underlying middle ethmoidal. Okay. So, what receives on the bulla? The middle ethmoidal cells. And in the hiatus, you can see an opening, right? That is the opening of the maxillary sinus to the infundibulum. To the infundibulum, on the wall of the infundibulum opens the anterior ethmoidal. And to the summit, the top of the infundibulum receives the opening of frontal sinus. So middle meatus is going to receive the opening of 4 important paranasal sinus. Okay, you can remember it by a mnemonic. Yeah, put here AMFM. Anterior ethmoidal, middle ethmoidal, frontal and maxillary. Okay, but they can separately ask you what opens into the bulla, what opens into the hiatus, what are the structures opening into ethmoidal infundiculum. Okay, if they ask separately also, you should be able to answer it. And this is the superior meatus into which the posterior ethmoidal group of air cells open into, right? So you can identify the sinuses here. This is the frontal sinus. Between the orbit and the eyeball, orbit and the nasal cavity, this is the ethmoidal. Can you make out the same here? This is your right orbit. This is your nasal cavity. This is the ethmoidal group of cells. Ethmoidal, anterior, middle, and posterior. And here, this is the maxillary. This picture is to show you the sphenoidal. Okay, sphenoidal. And here, yes, easy to identify the, yeah, I'll take a different color. This one, yeah, what are they? Frontal air sinus. Medial wall of the orbit, yes, the ethmoidal. This one here, maxillary sinus. This is an open mouth view, right, to show you the sphenoidal, right? So this is again an important topic in the nasal cavity, nasal region. Next one. Which of the following is not a feature of the palsy of the nerve involved? Okay, in the image given. So what is this image showing you? This is the right eye, the left eye. Which one is normal? Which one is abnormal? What is prominent in the left eye? You can see the left eye drooping, right? Ptosis. It is very characteristic of which cranial nerve palsy? Yes? Come on, tell me. You can enter in the chat box. Ptosis or drooping of the upper eyelid is common in, yes, which nerve palsy? Yes, the third cranial nerve, oculomotor nerve palsy, right? Due to paralysis of which muscle? Levator palpebrae superioris. Why does dilatation of pupil occur? Because the sphincter pupillae, which causes constriction or meiosis, that is paralyzed. Loss of accommodation is due to paralysis of ciliaris. Okay, so this is the odd one out. Why? Yes, oculomotor nerve, it supplies what muscles? Superior rectus, inferior rectus, medial rectus, yeah, inferior oblique, levator palpebrae superioris. Injury to the, paralysis of medial rectus will cause external strabismus, external squint. Okay, you won't be able to adduct the eyeball. You try to adduct, the eyeball will deviate outwards, causing external strabismus. Okay, yeah. A few points about the orbit that I want you to understand. So it's like a square, right? With the roof, floor, medial wall, lateral wall. So imagine this is the eyeball. The recti muscles are closer to the eyeball. So this will be superior rectus, inferior rectus on the medial wall, medial rectus over the lateral wall, lateral rectus, right? But other than the lateral wall, the other three walls, they have two muscles. Can you tell me what is that? Above the superior rectus, we get to say levator palpebrae superioris. Above the medial rectus, we get to see superior oblique. Below the inferior rectus, inferior oblique, right? So please remember, yeah, all the walls have two muscles except this lateral wall. And nerve supply, lateral rectus is sixth nerve. Superior oblique by the fourth nerve, all the others by third nerve. Coming to the actions of muscles, right? Easy. Lateral rectus and medial rectus, they have only one action, isn't it? Lateral rectus is going to cause abduction. Medial rectus will cause adduction. Coming to the other four muscles, superior rectus, inferior rectus, superior oblique and inferior oblique. Their primary action, superior oblique is going to elevate the eyeball. Inferior rectus will depress the eyeball. Superior oblique contraction will cause depression of the eyeball, and the inferior oblique will elevate the eyeball. Why? The oblique muscles are inserted behind the equator. Okay? The recti muscles are inserted in front of the equator. Coming to the other actions of these four muscles. Remember this mnemonic. The recti are going to adduct. Next, the obliques are going to abduct. Next, the superiors are going to, yes, cause intorsion. And the inferiors are going to cause, yes, extortion. So having this in your mind, tell me, superior rectus, apart from elevation, it is going to cause adduction of the eyeball. Recti is adducting, okay? Superior is going to cause intorsion of the eyeball. Inferior rectus, it depresses the eyeball. Other than that, that also causes adduction, yes, and extorsion. Superior oblique, very important, okay? It's already depressing your eyeball. Being an oblique, it's going to cause abduction and then superior intorsion. Superior oblique is very essential when you lower down your eyes to read a newspaper. When you walk down the stairs, it turns your eyeball down and out. Okay? Turns the eyeball down and out. Coming to the inferior oblique, what is it going to do? Again, it's going to abduct because it's an oblique muscle. Inferior, it's going to cause extorsion. Okay, so I'm sure you're thorough with all this. Easy to identify the muscle, right? So on the medial wall, you can see the tendon turning around the pulley, that is superior oblique. Below that, medial rectus. Lateral wall, only one muscle, lateral rectus. On the roof, which one is on the top? Levator palpebrae superioris. Below levator palpebrae superioris, superior rectus. And in the floor, what are these two muscles that you see here? Inferior rectus, inferior oblique, right? So identification of the muscle shouldn't be a problem. Now coming to the features of these nerve palsy. So this you know already, it's a third nerve palsy, right? Right and left, third nerve palsy. Now I'm going to give you a mnemonic to remember the features of third nerve palsy. Pedal. Ptosis, as we have seen, due to injury, paralysis of levator palpebrae superioris. External strabismus, due to paralysis of which recti? Yes, medial rectus. Dilated pupil, due to paralysis of parasympathetic component which supplies the sphincter pupillae. Loss of accommodation, due to paralysis of parasympathetic component that supplies the ciliaris muscle. Okay, now most of the muscle are supplied by oculomotor. So the eyeball itself sort of becomes flabby, right? That's why you get an apparent proptosis. So these are the features of oculomotor nerve palsy. Now looking into this image A, right, left. What is problem with the right eye? The patient has a difficulty to turn the eyeball down and out. So whenever he or she reads a newspaper or climbing down the stairs, there will be diplopia. So what is the muscle paralyzed here? Come on, enter in the chat box. The muscle paralyzed is superior oblique, right? Superior oblique. And the cranial nerve, which innervates it, is the trochlear nerve. Okay. Now coming to this image, see, again, right and left, right and left. So which is the problem here? Appreciate this one and this one. What is happening in the second part of image C? Now the right eye and the left eye wants to turn towards the right, okay? So the right eye is supposed to turn right. For that, it should abduct, isn't it? So the patient is not able to abduct. So what is the muscle paralyzed? It is the lateral rectus, which is innervated by the abducent nerve. Okay, so you should be able to identify the feature using the image given. Okay, which nerve is involved, which muscle is paralyzed. Right? Coming to this, a 50-year-old male who underwent parotidectomy complained of loss of sensation while shaving. Which nerve is affected more? That was a recent question in one of your INICT exams, right? Yes? Who's going to give me the answer? Come on. Make a guess. Please. Yeah, can I see the answers in the chat box? Waiting for your answers, yes? So you know that. What do they mean by this question? Yeah, loss of sensation while shaving, which is that area. It refers to the skin over the parotid gland. Skin over the parotid gland. Okay, what is the nerve supply to that? Yes, can you give me the answer? Yeah. So you know that the skin over the entire face, right? The skin over the entire face is innervated by the trigeminal nerve. Yes, except which area? The region over the parotid gland and the angle of the mandible. You see it shaded in a different color here, right? That area, the skin is going to be innervated by skin over the parotid gland, the lower part, or the skin over the angle of mandible. Right? That is innervated by, yes, come on, tell me. Great auricular nerve. This great auricular nerve is coming from cervical plexus. It's a branch from C to C3. Right? C to C3. Okay? Yeah. So few things. Why is it given in relation to parotid gland? Yes. So, you know, facial nerve is going to be entirely motor, supplying the muscles of face. Right? And mandibular nerve coming from the trigeminal nerve, it supplies the skin over the lower face. Great auricular nerve is the very apt answer for this question because it's going to supply the skin over the parotid gland. Why they have given auriculotemporal nerve as an option to confuse you, right? How is the auriculotemporal nerve related to the parotid gland? It conveys the secretomotor fibers. It conveys the secretomotor fibers from the parotid gland. Okay, so quickly we'll go through important points about the parotid gland. Okay, so the parotid gland, as you see here, yes, it's situated in front and below the ear, right? Yeah, parotid surrounding the ear. Yeah. Now there are important bony landmarks around it. You get to see the ramus of the mandible here, the zygoma above, external acoustic meatus, mastoid process. Medially, you get to see the styloid process also, right? So a lot of bony landmarks there. Okay, and you can see the submandibular salivary gland here. So you know that the investing layer of the deep cervical fascia, it is going to split to enclose the submandibular salivary gland. After that, it comes up, it splits to enclose the parotid also. For example, if you see this is the parotid, right? What is happening? The investing layer of the deep cervical fascia, it splits into two. a superficial layer which is attached to the zygoma here. Okay, which is attached to the zygoma here. It forms the parotidomacetic fascia. Parotidomacetic fascia, the superficial layer. Okay, what is happening to the deep layer? It's attached to the styloid process. It's attached to the styloid process and it forms a sort of a thickening that is going to be called as stylomandibular ligament. What is special about the stylomandibular ligament? It separates the parotid from the submandibular salivary gland, right? Okay. Now, yes, we get to see the facial nerve within the parotid gland, right? Yeah, the branches all we have seen, right? Now, what are the other structures within the parotid gland? Yes, the deepest structure within the parotid gland is the, yes, external carotid artery. We saw that the external carotid artery terminates at the neck of mandible, right? What is happening to it? Yeah, it's giving its terminal branches. One goes horizontally across the maxilla, the maxillary artery, and one goes upright, the superficial temporal artery. So external carotid artery within the substance of the parotid is going to divide into superficial temporal and the maxillary. And in the intermediate layer, we get to see the retromandibular vein, which is formed by the union of superficial temporal vein and maxillary vein. And the superficial structure, the one which is on the superficial part within the gland is the facial nerve. Now, I have a chocolate question for you. Can you tell me, this is the flag of which country? Yes, you see the yellow on the top, the blue in the middle, and the red below. Yes? Come on, waiting for your answer. You can give a try. Yeah? Take a chance, guys, okay? It's easier to remember. What is this flag? It's the flag of Colombia, okay? Yeah. So as you see here, 80% of the gland, where does it lie? It lies superficial to the nerve and the vein. So this plane, which divides the gland into a superficial lobe and a deep lobe, is called the faciovenous plane of Pate, right? 80% above and 20% below the plane. So that whenever you do a surgery of the parotid tumors, right? Yeah, pleomorphic adenoma is very common. You can remove 80% of the gland, right, without affecting the branches of the facial nerve. An abscess of the parotid. Okay, what type of incision are you going to make? A vertical incision or a horizontal incision? If you make a vertical incision, what is the damage you're going to do? You're going to cut across all the branches of facial nerve, right? So it's better to do a horizontal incision. This horizontal incision across the parotid, you have to let out the abscess. What is it called? Yeah, Hilton incision, right? Sometimes you can make a skin incision that is vertical, and then over the parotidomacetic fascia, you can make a horizontal incision to enter the parotid and let out the pus. This is called as blast incision, right? Now, what are the things you're supposed to know about the parotid duct? Yes, the Stenson duct. Yeah, it is about 5 centimeter long. You can see it running over the masseter after it emerges from the anterior border of the parotid gland over the masseter, and then it pierces the buccal pad of fat. It pierces the buccopharyngeal fascia. It pierces the buccinator and then the mucous membrane of the mouth to enter the vestibule, right? Yes. So this goes between the mucous membrane and the buccinator, sort of oblique. It's not straight passing through, okay? And finally, where does it open? It opens opposite the upper second molar tooth, okay? Upper second molar tooth. There's another important landmark, right? 1.25 centimeter lateral to the angle of the mouth, modulus, where a lot of muscles they crisscross before reaching the angle of the mouth. Okay, and injury to that can lead to facial asymmetry. Okay, this modulus is situated opposite the upper second premolar tooth. Okay, modulus is opposite the upper second premolar tooth, opening of the Stenson duct, upper second molar tooth, right? Yes. Yeah, in INACT exam, they keep asking you different components of the pathway, right? So this one, the secretomotor pathway for the parotid, it begins in the inferior salivatory nucleus. Ninth nerve, its tympanic branch, which is called as the Jacobson's nerve, that enters the middle ear to form the tympanic plexus. And the nerve that emerges from the tympanic plexus, it's the lesser petrosal nerve, right? This lesser petrosal nerve is going to synapse in which ganglia? The optic ganglia, which lies in the infratemporal fossa. And the postganglionic fibers, they pass through the auriculotemporal nerve, right, to supply the parotid gland. Okay, so remember the secretomotor fibers, right? The secretomotor fibers, they reach via the auriculotemporal nerve, whereas the skin over the parotid is innervated by the great auricular nerve from cervical plexus. So any injury to the region of the parotid gland, okay, parotid region, that can be a misdirection of the regenerating nerve fibers. Yeah, the secretomotor fibers, they are reaching the sensory fibers. So whenever you eat, you get perspiration, sweating over the skin over the parotid gland. And you're familiar with the syndrome? Yeah, Frey syndrome, right? And one important point to locate the facial nerve. This is the tragus, right? The tragus of the external ear. Okay, 1 centimeter below and 1 centimeter deep or medial to the tragus is the location, yeah, to avoid injury to the facial nerve. It's called as the Conley's point. Yes, please make a note of it, right? So if you are done with the parotid gland, yes. Now in these two pictures, yes, you can make out the difference, right? The right cord, yes, is adducted, is abducted. But what is happening to the left cord? It is kept in a cadaveric position. You are not able to either adduct or abduct. So what do you think? Which nerve is paralyzed? Can you tell me? Waiting for your answer. Which nerve is paralyzed? Yes, whether it's the internal laryngeal nerve or external laryngeal nerve or recurrent laryngeal nerve. You can enter in the, yeah. Atul wants to know about how many minor salivary glands are present, right? Yes. Different books giving different numbers. Yes. Yeah. You have the parotid, submandibular, and sublingual. These are the major ones. Apart from the minor salivary glands, like over the nasopharyngeal area, the one recently covered, but there are not major documentation on it, okay? And it's not an important key topic also. Yes, the internal laryngeal nerve, external laryngeal nerve, recurrent laryngeal nerve. Which one is responsible for the paralysis of the left cord? Yes, Akhil, Dr. Akhil, very good, okay? So we'll quickly revise about the, yeah. So what are the actions of vocal cord? What are the actions of vocal cord? You can tell me. You can either abduct the vocal cord, right? Or you can adduct the vocal cord. Yes, abduction is for respiration. Adduction is for production of voice, right? You can tense your vocal cord. What do you mean by tense? Like a rubber band stretching, right? When you want to increase the pitch of the voice, like to produce a high pitched sound, you can tense the vocal cord. or relax it. Now, what are the muscles responsible for it? Now, this image, you can identify the thyroid cartilage. The color of the pen, is it visible? This is the thyroid cartilage. Yes. You can make out the cricoid cartilage. This one is your cricoid. Sitting on top of the cricoid, this is the arytenoid. This is your ocal ligament. I will shade it green. This is the ocal ligament, right? This muscle just lateral to ocal ligament, what is it? That is the ocalis, right? The one next to it, too, I will label it. Just next to ocalis, that's the thyroarytenoid. This one which connects the cricoid and the thyroid, that is the cricothyroid. Okay, now connecting the arytenoid of both the sides, this is the transverse arytenoid. Okay, now this one going across, these are the oblique arytenoids. Sitting on the posterior surface of the cricoid, posterior cricoarytenoid. Inserting into the anterior aspect of the lateral process, lateral cricoarytenoid. Near the ocal ligament, ocalis, thyroarytenoid. Connecting the cricoid and the cricothyroid, cricothyroid. This is your transverse arytenoid, oblique arytenoid, and the posterior cricoarytenoid, lateral cricoarytenoid. Okay, the muscle which abducts your vocal cord, okay, which is going to abduct and then allow respiration to happen. That's the safety muscle of larynx, okay, the posterior cricoarytenoid. What are the adductors of the vocal cord? I'll write it here. So abduction of the vocal cord is going to be caused by posterior cricoarytenoid, that is the safety muscle. Adduction of vocal cord is caused by muscles which help to adduct the vocal cord, transverse arytenoid, yes, lateral cricoarytenoid, oblique arytenoids. The muscle, the only muscle which tenses your vocal cord, what is it? Cricothyroid, right? To produce a high pitch voice. Relaxation of vocal cord is by the one which is sitting next to your vocal ligament, ocalis and thyroarytenoid. Right? Okay. Now we know that all these muscles are going to be innervated by recurrent laryngeal nerve, except cricothyroid, that is innervated by external laryngeal nerve. Okay. Now tell me, yes, what are the function of each nerve? Internal laryngeal nerve is entirely sensory. It supplies the mucosa of the larynx above vocal cord. What will happen if it is going to be injured? Yeah, no muscle is paralyzed. Only that the sensation from the mucosa above vocal cord, like when you're going to aspirate something, when you normally food particles enter the larynx, you cough it out, right? But if the sensation of irritation is not happening, what will happen? Yes, that will lead to aspiration. Okay, coming to the next nerve, external laryngeal nerve, which innervates the cricothyroid. What does the cricothyroid do? It tenses your vocal cord, right, to produce a high-pitched voice. You want to shout and call someone who's standing far away, right? But you're not able to tense if the muscle is paralyzed. How will the voice turn out? You try to shout, but to others it will appear as a weak, husky, low-pitched voice, right? So here no sensory component, it's purely motor. Now what will happen if the recurrent laryngeal nerve is paralyzed? It innervates all the muscles. It innervates the posterior cricoarytenoid. It also supplies the mucosa below the vocal cord, right? So the three features of recurrent laryngeal nerve palsy, please make a note of it. It is going to cause aspiration. The safety muscle of larynx is paralyzed. The abductor is gone, right? So that will be difficulty in breathing, dyspnea. Most of the muscles of larynx are paralyzed. So the patient will have a present with a very hoarse voice. So internal laryngeal nerve, aspiration. External laryngeal nerve palsy, a weak husky voice. Recurrent laryngeal nerve palsy, three features, aspiration, dyspnea, hoarseness. Right? Yeah. Now coming to, I think this is the last part of today's session. We'll be winding up with this. What is trismus? Yes, it's also called the locked jaw, right? So what is the problem here? Patient is having difficulty in opening the mouth beyond a certain angle due to spasm of muscles of mastication. Now, what are the muscles of mastication? You know, yes, can you identify this? This is the temporalis. This one here is the masseter. So what are the things you're supposed to know about temporalis? Yes, it is a fan-shaped muscle over the temporal bone, right? What will happen if it contracts? Yeah, it is going to, the fibers are going to here pull your mandible up, also pull it back, right? Elevation, retraction, isn't it? Right? What about masseter? Yeah, before that, one more important point for temporalis. Which part of the mandible does it insert? Temporalis inserts into the coronoid process, okay? Yeah, which is hidden here. The coronoid process of mandible. So these are the 4 points you should know about temporalis. Fan-shaped, elevates and retracts, inserts into the coronoid process. About masseter, you can see the masseter originating from the zygoma bone, zygomatic process of mandible, inserting into the ramus, outer surface of the ramus. It is an example for cruciate muscle. And the contraction of masseter, what is it going to do? Again, it will elevate and protrude your mandible, right? It's going to elevate, close the jaw. Elevate the mandible and close your mouth, and it also causes protrusion. One important point to remember about the muscles of mastication is that all are going to be supplied by mandibular division of the trigeminal nerve. From which part of the mandibular division, mandibular nerve? It has a trunk, anterior and posterior division, right? So the mandibular division, mandibular nerve from its anterior division. Except one. Can you tell me what? There are 4 muscles of mastication. Out of the 4, 3 are going to be innervated from the anterior division of the mandibular nerve. Except one, you can enter in the chat box, right? You can enter in the chat box. What is that nerve? Yeah, coming to it. Now coming to the next one. This is the lateral pterygoid, right? It has an upper head coming from greater wing of sphenoid. A lower head coming from lateral surface of lateral pterygoid plate. This is the medial pterygoid. Both pterygoids, okay, the lateral pterygoid and the medial pterygoid come from the lateral pterygoid plate. But lateral pterygoid is called so because it comes from the lateral surface of lateral pterygoid plate. And medial pterygoid comes from the medial surface of the lateral pterygoid plate, right? Where is this lateral pterygoid going for insertion? Yes, it inserts into the capsule, into the articular disc of temporomandibular joint itself, right? Also into the pterygoid fovea over the neck of the mandible. This lateral pterygoid is the only depressor which opens your mouth. It opens the jaw along with the suprahyoid muscles. Don't forget the suprahyoid muscles, okay? The digastric, the mylohyoid, the geniohyoid are the other depressors. But of the 4 muscles of mastication, lateral pterygoid is the only depressor. Okay. Now we saw the medial pterygoid. Medial pterygoid, it inserts into the ramus on the inner surface. Something special about the medial pterygoid is it is the only muscle of mastication that is receiving its nerve supply from the trunk of mandibular nerve. All the other three are going to be innervated from the anterior division of mandibular nerve. Is that okay? Right? What is the action of lateral pterygoid and medial pterygoid together? The lateral pterygoid and the medial pterygoid, if they contract simultaneously, what will happen? It will cause protraction of the mandible. What is the other muscle that causes protraction of the mandible? The masseter, right? The lateral pterygoid and the medial pterygoid, if they contract alternately, what will happen? It will cause side-to-side rotational movements during chewing. Okay? Yeah, so that's all about the muscles of mastication. All of them, 4 muscles, what are they? Temporalis, masseter, lateral pterygoid, medial pterygoid. All of them innervated from the anterior division of mandibular nerve except medial pterygoid, which is innervated from the trunk. The muscle which causes retraction is temporalis. Protraction, masseter, plus simultaneous contraction of lateral pterygoid and medial pterygoid. The only depressor which helps to lower the jaw or open the mouth is lateral pterygoid, right? Yeah, this is out of interest, okay? So I'll explain it. This is A, B, C, and D. Which of the following muscle is not supplied by mandibular nerve? So this was asked in your previous exam. It's called the Toynbee muscle. Yeah, other name for tensor tympani. Can you tell me what is muscle B? Heard about Alice in Wonderland? Yes, which muscle? Temper, right? Yeah, person shouting in anger, temporalis, right? That's the temporalis, right? What about C? Mass eater, masseter. This is easy, right? Genioglossus. So of the 4, which one is not supplied by mandibular nerve? Genioglossus, okay? One word about this mandibular nerve. It is a nerve of which pharyngeal arch? It is a nerve of the first pharyngeal arch. How many muscles does it supply? 8 muscles. What are they? 4 plus 2 plus 2. What is this 4? The 4 muscles of mastication. Temporalis, masseter, lateral pterygoid, medial pterygoid. What is this 2? The 2 tensors, what are they? Tensor tympani, tensor palatini. And this 2 is the inferior alveolar nerve, which is going to supply the mylohyoid and the anterior belly of digastric. Okay, so it's a very, very important topic. These are the things you should know about the mandibular nerve, okay? The first nerve of the first pharyngeal arch and the 8 muscles supplied by it. So over the past, like nearly 2 hours, right? We have been covering all these topics. Okay, guys, we'll wind up the session. Any doubts, you can get back to me through Medusane. Yes, and just give your feedback about this session. If you find it useful, we can go ahead with it. Okay, like once in 2 weeks or once in a month. Yes, thank you, guys. Thank you, Raghu. Thank you, Medusane.
Thank you, ma'am. Thank you so much. It's very great to host you again, ma'am. If you have any doubt, you can just put it in the chat box so that ma'am can answer you. Thank you so much. Thank you, Akhil, for your active participation and others also have answered in the chat box. Thank you all.